from Kentucky and be with you to talk about this very important issue. I guess saying that I did meet Dr. W.E.B. Du Bois in Ghana does date me. He passed away in 1963, the very month of Dr. Martin Luther King's March on Washington. And he had laid much of the groundwork of the freedom movement in our country prior to that. And I didn't know anything about it, so maybe that speaks to our education system. But we all have to learn, right? Let me just say a few words about the work for H.R. 676. 676 is indeed the model bill for our nation. And it really is important that we unite around it and that we keep a focus on the national effort. The crisis in our country on health care has not reduced at all since the passage of the Health Care Reform Act in 2010. In fact, it is worsening. We have 50 million uninsured, and those of us who have insurance find that increasingly it doesn't cover the care that we need. So we're becoming a nation of the underinsured without the needed care. The costs are escalating rapidly and it is not sustainable. And the good news is that we have the support of our people. You know, I just hate it when people come up to us and say, all of the industrialized countries have passed national health insurance, but we can't do it because our people are not ready. I just want to share with you, the people are ready, and we have to do the job to move the nation forward. In Kentucky, and you know, they say we're backward. We're not backward. In Kentucky, we just had a survey done for how many people support universal health care, that everyone should be covered. 9 out of 10. So people want this. They want a program that will indeed bring all medically necessary care to everyone. And you see, some people say, well, that support isn't reflected in support for the reform bill that passed. That ACA, that Affordable Care Act, in Kentucky only has about 40% support. But if you ask, do you want everyone covered? Do you want everyone to have the right to get the care that they need? Kentucky is with this, the people of the country are with it, and our job is to figure out how to put into place a movement that changes that situation and makes what was impossible politically impossible because of the dynamics of that movement and the expression of democracy that has to come from that bottom-up movement. So I'm tickled to be with you today. Stay with the national bill. Some people are despairing and say we can only pass state bills, but if you divide up Medicare into 50 state segments, you'll destroy the best program that we have. So keep your eye on the prize. We're seeing that that it's going to become possible again, and our opportunity is going to be there. So it's really good to be in a place like this today. Okay, my job is to introduce Sister Mary Ellen, and I can't read this at all. Okay. Mary Ellen Howard is a native Detroiter, a sister of Mercy, and a nurse. She earned her BSN at Mercy College of Detroit, her master's in healthcare management from the University of Wisconsin School of Business at Madison, and was conferred an honorary Doctor of Humane Letters from the University of Detroit Mercy. For 20 years, Mary Ellen served as a healthcare administrator in Mercy hospitals across Michigan, including as CEO in Grayling and Muskegon. Since 1995, she has been executive director of St. Francis Cabrini Clinic of Most Holy Trinity Church in Detroit, the oldest free clinic for uninsured persons in the nation. She is actively involved in advocating for the local, state, and national level, and she does a tremendous job at raising the issue of what is and the hope of what can be. Sister Mary Ellen.
All right.
Good morning.
Good morning.
I'm glad to see all of you out here, some friends, certainly among the audience, with whom I've been working on this issue for a long time. Yeah, we've got our screen up there. Okay. Kay already did a good job of introducing me. I would just add to that this year I got a fellowship from the McGregor Fund, and they are asking me to look at the issue of the impact of health reform on free clinics, and so I'm spending part of my time doing that this year. What I'd like to cover with you briefly is tell you a little bit about St. Francis Cabrini Clinic of Most Holy Trinity Church, talk about the healthcare environment in Detroit where we function, and then who are the uninsured. So what I'm doing this morning is laying out the problem, the issue. What is the need? Free clinics are nonprofit organizations that use volunteer health professionals to provide free health care to uninsured persons. And that's a picture of the front door of Cabrini Clinic. So that's the definition of a free clinic. We use volunteer health professionals to provide free care to uninsured people. Our medical director, Dr. Susan Schooley, has a different definition of free clinics. She says they're the safety net below the safety net. And a lot of people are falling through that net. Let me say a few words about the healthcare safety net in Detroit. We have a population of 700,000, give or take a few thousand, in Detroit, and of those, 200,000 are uninsured. That's a lot of people. It's the poorest large city in the nation. We have no public hospital. The closest thing we had to it was Detroit Receiving Hospital, and recently they went for-profit, as you know. Hospitals are closing, have been closing over the years in the city, the past few years, and many of the hospitals see their future in the suburbs, where you look, where you say, well, where are new hospitals being built? It's in the suburbs. And they use the city as their excuse. They say, well, we have to build in the suburbs, that's where the money is, and we need to support our mission in Detroit. And I hate it when they say that. Because it's just, they're, again, the poor are being used as an excuse to do what they want to do. We have the second worst health status of any major city in the country. I don't know who the worst is, but it's got to be pretty bad. The highest rate of preventable hospitalizations. These are for things like diabetes and asthma. You shouldn't be hospitalized for those conditions because there's preventive treatment available. If you have access to the medications that you need, you won't be hospitalized. But in Detroit, people don't have access. There's a shortage of primary care physicians and federally qualified health centers. We're trying to correct that, but it takes resources, and as you know, Detroit hasn't got too many these days. There's many health status measures where Detroiters fare worse than the state and the nation. And some of those are hospitalizations for asthma, infant mortality, HIV, hepatitis B, late-stage prostate cancer, invasive cervical cancer, and late-stage breast cancer. A lot of those that are listed as late stage, why did they get to late stage before they got to a doctor?
That's right.
Too many barriers. So let's say a few words about Cabrini Clinic. I've shown you the kind of the environment in which we function. Let's say a few words about the clinic and what we do. It was founded in 1950. It's the oldest free clinic in the nation. We treat uninsured adults ages 19 to 64. And the reason for that is that below 19, Kids pretty much can get access to health insurance through Medicaid or My Child. And of course, above 65, folks like myself we have universal coverage called Medicare. Thank God. We see about between 100 and 150 people a week. In 4 clinics, we have 3 primary care medical clinics and 1 mental health clinic every week. We have 5 full-time staff, including 2 volunteers. I'm a full-time volunteer at the clinic. We have an operational budget of around $300,000 and more than 100 volunteers who give their time and skills to provide the care for our clients. We also are involved with a lot of the area universities, and we got all kinds of students who are coming to learn what it is to be sick and poor and uninsured in the city of Detroit. They learn a lot from our patients. We provide primary care, prescription assistance, and mental health care. Prescription assistance is probably the most important service that we provide. It's the #1 reason why people come to us. They may be able to figure out how they get to a doctor, but they sure as heck can't figure out how to pay for these prescriptions that add up to $600. So all of our patients get all of their prescriptions for free. So who are the uninsured? They're above age 18, we talked about that, and below 65. They have to, in Michigan, you are not eligible for Medicaid if your income is above 35% of the federal poverty level. And we're going to talk a little bit more about that, but that's absolutely dreadful. That's nothing. That's nothing. So many of the clients that we take care of, make a little bit more than 35% of federal poverty. They still can't pay for their care. Single adults are excluded from Medicaid. Minorities are more likely to be uninsured. And many of them are working, many of our clients are working, but they're in low-wage jobs without benefits. Some of them in 3 and 4 jobs, being paid under the table or whatever. I said that at Cabrini Clinic we treat those ages 19 to 64, but if you look at our waiting room, who's sitting there? It's people ages 50 to 64. They're especially vulnerable. At age 50, I would say most of us in this room have reached that mark. And you know that you start to experience chronic diseases, whether it's hypertension, type 2 diabetes, or whatever. And you find that after age 50, you need to see a doctor more often than you did before. So they're especially vulnerable at that age, and particularly for chronic diseases. And they can't afford the care or the medications they need to stay alive and healthy and out of the emergency room. At Cabrini Clinic, traditionally, I want to say the patients that we've seen in the past, when I first came there, and I've been there 17 years, they were people that were born into poverty. And they grew up in the social welfare system, and they knew how it worked, and they knew what food stamps were, and how to get them, and how to get some help. And they knew how the system worked, and they knew when they were lying to them, they were lying to them. But I want to say the folks that we're seeing, the new patients that are coming in the doors these days, did not grow up in poverty. They grew up in the middle class. And once they lost their job and lost their benefits, soon they lost their home, and they have nowhere to turn. And they really don't know how the social welfare system works. And so they require a lot more care from us. I always say that the social worker that we have, her job is probably the most important at Cabrini Clinic, more important than the medical professionals, because if you're a diabetic, it doesn't make too much difference whether we're writing a prescription for Lantus insulin for you. If, in fact, you don't have your utilities turned on, and you lost your house, and there's no refrigerator, there's no food in the house. Those basic needs have to be addressed first. So that's who the uninsured are. And here are the uninsured. This is our waiting room, and these are our patients, some of our patients. And They're wonderful people. They're great people, great courageous people who make great sacrifices to come to the green flag. Let me just say a few words about some common myths about access to care for the uninsured poor. I heard, our former president, George Bush, said the uninsured poor can always go to the emergency room for care. They have access to care. Right. They can go to the emergency room, but will they get in the emergency room what they need? No. If you're an insulin-dependent diabetic and you can't afford $150 for a little vial of Lantus insulin, you're going to end up in the emergency room in a diabetic coma. What they'll do for you there is stabilize you and hand you a prescription for Lantus insulin. When I say a prescription, I mean a piece of paper. And there you are. What good has been done? You're right back where you started. You still can't afford to buy the Lantus insulin. So that is not the answer. Secondly, if you're poor enough and sick enough, you can always get Medicaid. That was a great revelation to me when I first came to training 17 years ago. I thought if you were poor enough and sick enough, you could get Medicaid. It's not true. In fact, it doesn't make any difference how sick you are. Sickness does not enter into the whole equation of eligibility for Medicaid. It's all based on your finances. And there are a lot of poor people that are not eligible for Medicaid. I'll show you those numbers in a minute. If I can get a Medicaid card, third, I will be able to have my own doctor. Well, good luck. The Affordable Care Act is going to expand Medicaid to a lot of people. We're not going to talk about that so much this morning, but my fear is that even when they get a Medicaid card, will they be able to find a doctor who will accept Medicaid? Because the reimbursement rates for Medicaid are so low, most doctors just say, I won't bother with Medicaid. So they don't accept Medicaid patients. And we already have a shortage of primary care physicians, but especially physicians who accept Medicaid. And I want to say another myth right now, just to add to that, is sort of, if I have an insurance card, I have access to a doctor. Not just a Medicaid card, but have you noticed what's happening to the co-pays and deductibles? Who of us can afford that? It's just getting worse and worse. Here's the facts on federal poverty level. For 2012, the federal government says that you're poor if your income as an individual is below $11,170. So that's how the feds define poverty. Now, I don't know how you live on $12,000 a year, but the feds say, that you don't fall within federal poverty guidelines if your income is above that. But in Michigan, eligibility for Medicaid is only 35% of federal poverty. So in Michigan, if you make more than $3,910, you're not eligible for Medicaid. You are too rich. That's not $3,000 a month. That's $3,000 a year, folks. How many of you knew that? Isn't that awful? I mean, we should be outraged. That's just crazy. Most states have 100% of federal poverty, or they have, Wisconsin has 200%. We have 35%. That's crazy. So what happens to you if you're uninsured? You have no regular source of health care. Needed care is delayed or deferred, not sought. You just say, well, I'll just put up with this pain. There's no preventive care or checkups. 50% of those aged 40 to 64 who are uninsured have never had a mammogram or colonoscopy. 50% of women aged 40 to 64 who are uninsured have never had a mammogram. That's terrible. Of course, medical bankruptcies. I know you've all heard about that. It's the #1 cause of personal bankruptcies is medical bills. And you're more likely to be hospitalized unnecessarily because you put it off. he put off going until it became a, you know, as we would say when I worked in the ER, train wreck. Here comes a train wreck. More likely to be diagnosed with late-stage cancer, and there are higher death rates. It all follows. I want to tell you a story. This is a story that hit home for me. My cousin Pat, his oldest son Joey, is 49 years old. He was an uninsured substitute teacher in the Warren School District. He had a heart attack last year and was hospitalized for it. Came out of the hospital with hospital bills of a couple of $1,000. Of course, because he's a substitute teacher, no benefits, all right? So uninsured, he gets the whole hospital bill. And so he's trying to figure out how he's going to pay for this. He was up north at the family cottage, and he fell. He was sweeping leaves on the porch, and he slipped in the leaves and fell and injured his kidney and liver. He didn't go to the doctor at that point because he already had all these other hospital bills. But a week later, he said to his mother, "Mom, if my urine is the wrong color, is that a problem?" She said, "Joey, you got to get you to the doctor. What's going on? What happened?" Well, it turned out he had both kidney and liver damage, and he was again hospitalized, and this time he came out with tens of thousands of dollars in hospital bills. He was in the process of filing bankruptcy. Told his dad that he, there's just no way I can pay this dad on my income. What am I going to do? I guess I'm going to have to file bankruptcy. On Christmas Eve, he was at his parents' house, and he said to his mom, "I don't feel good. I'm going to go home and go to bed." He went home and went to bed and died. And, Joey died of uninsurance. That's the diagnosis I would give him. He died because he didn't go to the doctor when he should have gone to the doctor. And why didn't he go? Because of the hospital bills. And why did he have the hospital bills? Because he didn't have insurance. That will not go on his death certificate, but that's why he died. And there are a lot of people in that situation, in that kind of situation. A 49-year-old young man shouldn't have died, unnecessary death, because he was not insured. It all could have been fixed. This breaks my heart. There's a Haitian proverb that says, "Where you stand determines what you see." And looking at the whole issue of healthcare in this country, if I'm the head of a drug company, I might look at our healthcare system in one way. I'm the head of an insurance company, I might look at I'll have a different view of our healthcare system. But where I stand is with the uninsured poor in Detroit. And so that's my view of the healthcare system. And as a result of that, I believe that healthcare is a human right.
Yes.
Other ways of saying that healthcare is a human right. People have value. We can't just let them die. That's what's happening. The right to life includes the right to healthcare.
Yes.
Amen. And then putting it in a religious context, which I can't help. I have to do it. Do unto others as you would have others do unto you. Love your neighbor as yourself. Whatsoever you do to the least of my brothers and sisters, you do to me. That's another way of saying healthcare is a human right. Here's some of my friends marching in the Labor Day parade with a banner. That's Selma Good right up there holding up the banner in the front. And Father Norm Thomas in the hat over on the left. This is Dr. Flowers is going to say a little more. I've kind of laid out the problem for you, and she's going to say a little more about the solution, but certainly it is healthcare for all. Amen.
All right.
We'll take we'll take questions a little bit later after Dr. Flowers speaks, and they're going to be passing out little cards that you can put your questions on. So if you have questions about anything that I have presented, please write them out in cards, on one of the cards, and they'll be collecting them, and we'll address questions a little bit later. Thank you very much.
Good morning. I'm Dr. Paul Manoia. I'm a mostly retired obstetrician. I've done high-risk obstetrics for about 96 years in the Detroit area. And I'm active in the Detroit area social justice mission team of the United Church of Christ. And I'm proud to say that we have supported improved Medicare for all single payer. I'm also one of those national doctors. I don't think you can see my button from there. Who's also a member of Physicians for a National Health Program. And I'm honored to introduce our keynote speaker, Dr. Margaret Flowers. Dr. Flowers is a pediatrician from the state of Maryland. Has worked at a rural hospital as well as in private practice. But she decided to become a congressional fellow for Physicians for a National Health Program and spoke out at the Caucus Senate Finance hearings when it became obvious that single payer was being excluded during the formulation of the Affordable Care Act. And I don't know why. It certainly would make things a lot simpler in our healthcare system. There we go. See, there's our current system on your left, and there's Uncle Sam trying to decide to push that button, or he's looking kind of longingly over to the other side. Single payer would certainly make things a lot simpler. Well, after this, Dr. Flowers was interviewed by Bill Moyers on PBS, and she had attempted to deliver to the White House her view of health care reform that would include everyone, cut costs, and I think most importantly, change the basic incentive of health care to one of keeping people healthy, and not just providing an opportunity for corporations like insurance companies to make money for a few by excluding the high risk and the poor. Dr. Flowers was an organizer for the October 2011 Occupy Washington, is on the board of healthcare now, and is a co-director of It's Our Economy U.S. Some of us were fortunate to meet Dr. Flowers during the U.S. Social Forum in Detroit in 2010. That's the slide now. When she led us in a spontaneous demonstration for improved Medicare for all outside of Cobo Hall. She's just flown in from a similar Medicare for all event in Maine, and that's really what she does all the time. Her topic this morning is entitled Ending Wall Street Healthcare and Creating Healthcare Justice. Will you please join me in welcoming Dr. Flowers back to Michigan.
Thank you for inviting me to be here today with you to speak. And thank you, Sister Mary Ellen, for that wonderful talk and really laying out what I'm going to say. And actually, I imagine that most of you are already going to know a lot of the things that I'm going to say. What I'm hoping to do is give you some language, if you need that, to help you talk to others. Because this is what we need to do, is we need to take this movement from beyond this room outward and continue to grow and expand it. That's how we're going to get health care for everyone. So let me myself figure it out here. Okay. So it's appropriate that Sister Mary Ellen talked about health care as a human right, because right now what we have is Wall Street health care, and what most other industrialized nations have is human rights-based health care. And in the United States, we ourselves are members of a country that signed the Universal Declaration of Human Rights, which in Article 25 stated that health care is a human right. So what does that mean? When we use the principles of human rights, there are 5 basic ones that we put forth, and one is universality. Everybody in, nobody out.
All right.
Equity, that each person has what they need to get the same standard of care. And everyone order it. Transparency, accountability, this is what we get with the public process, and participation, that we should have some say over our healthcare system and what our priorities are. What we have in the United States, instead, is a market-based system. What we have is a system that was not ever designed with the intention of becoming a healthcare system. The fact that we tie insurance to employment is not done, that's not done anywhere else. That was a fluke of history during World War II, when wages were frozen and employers started using health benefits to attract employees. That was never meant to be the basis of the system. And then in the 1980s, there was a concerted effort to start privatizing our health care. And so now we have over 30 years of experience with a privatized healthcare system. We're really the only industrialized nation that uses a market-based approach to healthcare. The outcomes are extremely clear. The experiment is over, the results are in. We have the most expensive healthcare in the world. We have fairly poor outcomes for the amount of money that we're spending. We have rising health disparities. We're losing our doctors. We have a growing number of uninsured and underinsured, the highest number of preventable deaths. So we know what this market model does, and it doesn't work. Let me go through that a little bit with you. Because this slide shows a number of industrialized nations with the United States at the top, comparing ourselves to Canada, France, Germany, Sweden, the UK, and Japan. Those other countries all cover pretty much everybody within their borders, and they have better health outcomes. What the red bars represent.
Can you hear me if I just speak loudly? No. Yes?
The mic went out.
Okay. Oh, while we're waiting, okay, if we can get that fixed. Well, the lights on, that's good. There's not like a view. Can you hear me now? No. Can you hear me now? No. Okay. The lights on. Okay. Anyway, if we look at the red bar represents public dollars, public spending on healthcare. And what this shows is that you compare the United States to these other nations, we're already spending more in public dollars per person per year than they are. And if you add in the total amount that we're spending, which includes the private dollars that go into our healthcare, in many cases we're spending twice as much. So we're already spending enough in this country to provide high-quality, lifelong, comprehensive care to everyone. We're just not getting it. So if anybody says we can't afford it, you tell them, no, we're already paying for it. This is a slide that shows, that helps me to illustrate why we're paying so much for health care. If you look at the growth of physicians over time in the U.S., now look at the growth in administrators. That's 3,000% at the top there. These administrators add nothing to our health. They're there to design insurance plans, to market them to you, to help you figure out which plan you can qualify for. Then once you have a plan, where you can go, and then once you go and get your care, who pays how much, you do. It's very bureaucratic, and it's really designed to block the delivery of care, and I'll go into that next. It's estimated that a third of our healthcare dollars are wasted on marketing and administration. That comes out to $400 billion a year. That could be going to direct patient care. The reason for this is that within any population, there's something called the 80-20 rule. 80% of the population is healthy at one time. 20% uses 80% of our health resources. But people go in and out of that 80%.
You know, Joey had his heart attack and he was in that 20% that needed care, then he was doing better, he came back out of it again. You know, we could walk out this morning and have an accident and suddenly be in that. So what the insurance companies are trying to do, and the reason that they have a lot of these administrators, is they're trying to insure those who are in that bottom 80% on the left, the ones that are healthy that don't actually need health care. And they're trying to exclude or dump those who are in the 20% that need care. And those 20% usually, if they lose their insurance, end up being on public programs or being uninsured. And one of the newest ways, and Sister Mary Ellen alluded to this, the newest ways to try to keep from paying for health care by insurance companies is the advent of these high deductible, they're called consumer directed. Watch the language, because we didn't hear about patients as consumers until the 1980s when we started to privatize our health care. When I grew up, patients were people, they were not consumers. They were people who needed care. So we need to be careful about our language. So these plans are the high deductible plans with high co-pays, high co-insurance. So you may pay, say you pay $10,000 or $12,000 a year for your health insurance plan. If you have a $5,000 or $10,000 or $15,000 deductible, you have to pay that much more before your insurance actually kicks in. And those have to be covered services. So the insurance company can say, well, that's not a covered service, that doesn't apply towards your deductible. And then even after you hit your deductible, you may have to pay a co-insurance, so you're still paying a portion of your health care. The reason well, let me quickly go through this. This is a slide that just goes a little bit about the trend that we're seeing in the United States, because we're seeing a growing trend of more people ending up in these high deductible health plans that don't protect us. On the employee market, which is the one on the left, people that get their insurance through their employers, in 2009, about 20% of people had these high deductible plans. That was an increase. But in the individual market, those who get their health insurance outside of their employer, was nearly 50% in 2009. We anticipate that under the Affordable Care Act, that trend is going to continue. In fact, McKinsey Company, a consulting firm, estimates that in 2014, 30% of employers that are providing insurance are going to dump it. Or as we saw, that there was an article that said, it quoted a head of a corporation who said, nobody wants to be the first to drop employee-sponsored health care, but everybody wants to be second. What are the results of being in a high deductible plan? Well, this was a very basic study that was done looking at people who are on the privatized portion of Medicare, the Medicare Advantage HMOs, which is basically a private insurance, and what happened to them after they raised the co-pays. Because there's this idea, we keep hearing, that we have to have skin in the game, that if we actually know how much we're paying for our health care, we'll be more careful about how we spend our health care dollars. So this was a study looking at what actually happens. When they raised the co-pays, they saw fewer people going to the doctor, fewer outpatient visits. But as a result, they saw more hospitalizations and longer stays, because people did exactly what Joey did. They waited until they really had to go, and then something that could have been treated more simply became more serious. And the studies have shown that if you look at people all across different educational backgrounds, people are not able to determine what's necessary care and what's not necessary care. So if you give them a financial barrier and it becomes a financial decision, yes, some people avoid care that they didn't need, but people also avoid care that they really needed. So putting those barriers in there harm our health overall, and they don't save money in the long run. We're right now in this cycle, this unsustainable cycle, where insurance premiums are renewed, plans are renewed every year. So if you look at the top, every year our premiums go up, right? Yeah. Really funny, not funny, ironically funny. The Department of Health and Human Services said that they will only investigate insurance premiums if they rise over 10%. If you raise the premiums less than 10%, you fall under their radar. So a recent study done this year by Buck Consulting showed that across the board for all types of insurance plans, anybody want to guess how much they're going up this year? 9.99% for every single one. Every single one. So anyway, premiums go up. So what do people do? in these financial times, if they can still afford insurance, they go with these high deductible plans because they're less expensive. But when you have more out-of-pocket costs, then you seek less care. And when you seek less care, you're at risk for having more serious problems. And you can bet that if you have a more serious problem, your insurance premium is going to go up more the next year. And then people also get into the cycle of, now that their medical bills are mounting, they have a serious problem, they end up dumping their health insurance so they can try to pay off their medical bills. And we're on this cycle, and at some point, people are falling off quickly into the uninsured pool. So we now have around 50 million or so people in the United States who have no insurance. And you can see that those numbers really started to rise after the 80s, after we privatized healthcare. That's what markets do. Markets are based on inequality, that you can only get, what you're able to pay for. Who are the uninsured? Sister Mary Ellen talked about that, so I won't go into it, but so many of them are working families, especially people that fall outside of that window of qualifying for public programs. And what's the result of having so many underinsured and uninsured? It's a high number of preventable deaths. There was a study where they looked at 19 different industrialized nations and compared them on the number of lives that would be saved if each of those systems functioned as well as the top 3. The best countries in the world are France, Japan, and Australia. The United States came out last, 19 out of 19. It was estimated that if we had one of the best health systems in the world, we would prevent over 100,000 deaths each year. It was estimated that if we were even average, we would save over 75,000 lives each year. 75,000 lives. Can we wrap our head around how big that number is? So what's happening to people who are uninsured and underinsured? Medical illness, medical costs are the greatest cause of personal bankruptcy in the United States. It's 3,700 people a day who declare personal bankruptcy in the United States from illness or medical costs. And almost 80% of these people had some form of health insurance when they got ill. All right, so the Patient Protection and Affordable Care Act was based on a model that has already been tried at the state level. And so we know how it's expected to perform. We also, the Congressional Budget Office did studies estimating how they think it's going to perform. Even at its best, when it's fully laid out in 2019, they expect that only half of the uninsured will gain coverage. The estimates initially were 23 million would be left out. Most recently, the estimate was 28 million are going to be left out. What we know is at the state level, every time there was a sort of a comprehensive health reform and they estimated how many would be covered, they never got it right. It was always less than what they said. We're going to continue to have increasing total healthcare spending. We're going to have a continued trend of underinsured. We're mandating that people purchase insurance, but not that that insurance actually guarantee that they can afford the healthcare that they need. And while we so much heard that people want a choice of health insurance, what we find is that people don't actually want a choice of health insurance. People want a choice of where they go to get their care. They want a choice of what kind of care they get. And those are the two things that private insurance restricts. They tell you where you can go to the doctor and what kind of care you can get. So, this airplane represents the United States healthcare system, and these guys down there, we tried every fix the insurance companies will allow, but it still won't fly. This is where we are, okay? We tried it at the state level, and now we're trying it at the national level. The insurance companies wrote the legislation. This is what they would allow. It's not going to fly. While it has some good aspects and some more people are gaining care, overall, it still leaves people out, and it's not going to fly. So what do we need? Where do we need to go? This is what single payer is. This is not an experiment. This is based on what has worked in the United States with our own Medicare population and what has worked all around the world. The basic principles are one single pool, everybody in, nobody out, right? Everybody in, nobody out. Continuous. So there are no cracks to fall through, not getting care. Everybody contributes based on their ability to pay. The United States is the most unfair. We're 54th in the world for fairness in financing of our health care. So the lower your income is, the more you pay as a proportion of your income towards health care. That all medically necessary care is covered. This is really important because if we have to have supplemental insurance plans, we're still complicating the system. It just needs to be very simple. You saw that one slide that Paul showed. Healthcare, pay for it, goes directly to the patient. Simplified administration saves money, estimated over $400 billion a year. When people say that the government is bureaucratic, the government is inefficient, it's actually the exact opposite. Medicare system runs 3% administrative costs compared to private insurance, which is 8 to 10 times that. Choice of physician and treatment, that's what people want. Focused on preventative and timely care, because private insurance companies have no interest in preventative care. They don't have a long-term investment because they know that premiums are renewed every year. They know that people switch their insurance after a few years. They also know that when we turn 65, they don't have to worry about us anymore. But when you have a national health insurance that's taking care of everybody for their whole life, they care about that. And we need to remove the barriers to care. That's what timely care is about. We shouldn't be making financial decisions when we get sick. So no copays, no deductibles, so that there are no barriers. And it needs to be transparent and accountable to us. So how do we do that? Okay, so the model bill is H.R. 676, introduced by John Connors. The United States National Health Insurance Act, otherwise known as Expanded and Improved Medicare for All. And Dr. Marcia Angel, who is a former editor of the New England Journal of Medicine and a national expert on healthcare financing, says it very clearly. We will never be able to control healthcare costs and provide quality healthcare to all Americans until we establish a healthcare system with single-payer financing. So how are we going to get this airplane off the ground, this U.S. healthcare airplane that's all bandaged and cracked up? People say we need incremental change. I agree with you. But there are two smallest steps, incremental steps that we can take to get us on the road to having a high-quality healthcare system. These are the lowest, the tiniest steps that we can take is to create a system that's based on health, where we're using our resources to improve the health of our population. And the other step is to get the financing to pay for it. And that's what single payer does. It's the most efficient way of using our healthcare dollars. We're already spending enough, but instead of spending them on administration, we need to spend them on healthcare.
Right.
So we based this on something called the Principles of the Physicians Working Group Proposal. It's on the PNHP website, pnhp.org, and it's really simple to read. Well, where are we headed? This is the scary part. We're seeing increasing privatization of our health care.
No.
As the health insurance companies are losing people who can afford to buy their premiums, they're turning to our public systems, and they're starting to take over our Medicaid and our Medicare and use those as ways to make money. They're looting our public systems. And this is what the Affordable Care Act does too. It's a huge bailout for these industries. It's using billions of our public dollars to go directly into the private insurance corporations. This guy, you may recognize, Paul Ryan. He wants to completely dismantle our Medicare. He wants to make it a voucher system so that instead of people having a guaranteed Medicare benefit, you get some money to purchase private insurance. And the amount of money that voucher is going to go up each year is less than our healthcare costs are rising. So over time, that voucher becomes worth less and less. He also wants to change our Medicaid so states only get a certain amount of money. And so it's not, right now it's not based on money, it's based on need. How many people in your state meet the criteria? He wants to just give states a little bit of money and then they can fight over who gets to be covered or how much services they provide. So right now there's a Supreme Court challenge on the individual mandate. That's going to be decided in June. If they decide the individual mandate is not constitutional, there's going to be a huge opportunity for us to say, okay, you tried this at the national level, it didn't work, let's just go to Medicare for all. Really simple, Americans want it, we understand it, let's go to that.
All right.
We also are seeing austerity measures. We're being told that we have a huge deficit in this country and we have to accept austerity measures. This is not true. Back in the 70s, 60s, 70s, 80s, we had huge, very high tax levels on those who are wealthy, 70, 80, 90%. Nobody paid those tax levels because they kept their incomes down and reinvested their profits in their businesses and made jobs. Now they're hoarding because they can. So we have a revenue problem, not a deficit problem, but we're being told the opposite. So how do we get real health care reform? The 3 lessons that I learned when I was pushing at the national level for us to get a single-payer bill. Fall into the initials, ICU, so it's really easy to remember, especially if you're a healthcare professional. We have a crisis and we need intensive care. We need the ICU. We need to be independent. We need to focus on the issue, not someone's political agenda. We have to stand away from that political agenda, and no matter who is in office, to tell them what we want. Focus on the evidence of what works and the issue. We need to be really clear about what we want, because there's a lot of misinformation out there. So we need to understand what is universal, what is guaranteed, what's affordable. It's a single-payer system. No other system. As long as we keep the private insurance in there, it's not going to be a universal or affordable system. And we need to be uncompromising. We need to stop accepting what we're given. And this is a difficult thing to do. I struggled with this as well, because I started out pushing at the state level for reform. And when we were told that all we could get this session was a Medicaid expansion, or all we could get was a tax credit for small businesses, or these small changes, it's really hard to not support that, because you know that a few more people are going to get care. But it's not the real solution, and none of these tiny steps have moved us forward. Our uninsured numbers continue to rise. Our healthcare costs continue to rise. So now I feel very comfortable saying, no, I'm not accepting that. I want every single person in the United States to have the same standards. As long as people's in, they'll take it. And what did Frederick Douglass say? Power concedes nothing without a demand. So, we are not going to elect our way out of this current situation. These are not the complete solutions. We're not going to email our way out of this situation.
That's right.
And these are pictures of Spain and Egypt, where many people have stood up against austerity measures. I wanted to tell you quickly why I was one of the organizers of the occupation of Freedom Plaza in Washington, D.C. Because we started organizing that occupation in April of 2011, before the Occupy movement came about. And it was because healthcare is actually part of the broader struggle for social and economic justice. This slide is taken out of a book called The Spirit Level. It was written by some public health people in the United Kingdom. And they took countries around the world and they looked at how much difference there was between the rich and the poor. And they compared that to what they call indicators of social well-being. So things like education, violence, health, even trust. And in every single indicator, the United States was an outlier. See us? Every single one. We're at the greatest degree of wealth inequality in the United States that we've ever had. You can't have democracy when you have this degree of wealth inequality, because those who have the money have the power. And you can't have a healthy society with this degree of wealth inequality. So even if we got access to health care, if we still have people that are homeless, that can't eat, that don't have a job with a living wage, that live in a polluted environment, they're not going to be healthy. But if we join together in our struggles, we'll have the numbers and the power to overcome that money and that power. So that's why I occupy. This just shows you the wealth divide if it were done geographically. So the 1% owns all that land, 9%. So you see the top 10% owns most of the United States. The next 30% owns that southern patch. The next 20% owns part of Texas. And the bottom 40% own that little teeny red dot that you can barely see. That's the wealth inequality in the U.S. So what we really need to do is come together. This is a picture of doctors and health professionals who joined with the Occupy movement to march in the streets. So let's build a movement, let's educate ourselves, and let's be uncompromising in our demand for health care for every single person in this country. Thank you very much.